thank you very much. And I will start by saying that I talk about health impact assessments a lot to a lot of different audiences, and never in my career have I had a 3-hour-long introduction to why we need them. This was great, and I really congratulate the committee on organizing such a wonderful morning. The prior panels have been great. I'll hope to build on some of what they've said. I barely need this slide, but I do want to make the point that I think the conversations that are happening in this room are really part of the foundation for a new approach to public health. We've had a way of doing business that's evolved over well over 100 years. We're now recognizing, as this body said more than 10 years ago, we can't do it alone. We need other sectors. We need to integrate health criteria and decision-making across multiple sectors. So this is all great. It's really exciting that we're saying this. But that's not to say that it's a simple thing to do. And I think each panelist today has given you different ideas of things that we can do, all of which are important. Health impact assessment helps fill one niche. I think to the workforce question that someone asked the prior panel, I would say, you know, we built epidemiology to respond to infectious epidemics, largely. We're now trying to invent cross-sector public health, and we need tools for that. And one of those tools I would submit is health impact assessment. This is a way to address problems such as when we're trying to work with another sector, they don't understandably necessarily have a background in public health or understand the issues that we'd like to bring to their attention. We similarly, and probably more importantly, don't really understand, as I think Beth Osborne from DOT pointed out very strongly this morning, the process through and constraints, political constraints, funding constraints, legislative constraints on the way that they do their business. So without understanding that, it's difficult for us to make recommendations and suggestions that are effective, that fit well within their mission. There's not a lot of funding for new activity. Someone I asked about funding for doing health impact assessments, and that is a question that I'll address because I think it's a very important one. And there aren't a lot of formalized requirements for doing this work. We all in this room want to do the right thing, and that's why we're here. But let's face it, legislation isn't often driving us to work together. So how do we make all of this happen? Since we've spent a lot of time on land use planning and urban environments, I'm going to take you far away to my homeland in Alaska. I'm a physician and spent the better part of 8 years providing primary care to rural Alaska Native communities. And I fell headlong into the world of health impact assessment through oil and gas politics in Alaska. The Bureau of Land Management was conducting an environmental impact statement to examine the proposal to open a vast tract of land near several Alaska Native communities to oil and gas leasing. These communities actually really support oil and gas development. They have a $300 million a year local government budget that comes mainly from oil and gas revenues, very important to health. For example, it creates their health department. But at the same time, this is where they get their food, and this is a tremendously culturally important area, and also where they hunt and fish. So people were quite concerned. What happened actually, though, was instead of beating their heads against the wall at community meetings, the local government became a cooperating agency, which is something allowed under the regulations that drive the environmental impact statement process. And in that role, they actually drafted a health impact assessment that was incorporated into the EIS. The health impact assessment addressed a wide range of health determinants. We went far beyond air and water quality, so which are the things that I think come most immediately to mind when you think oil and gas. People talked a lot about food security and diet and dietary change, the influx of non-resident workers and the risk of alcohol and drug trafficking to previously very remote, isolated communities. They also talked about benefits such as revenues and employment and income. So I'm not going to tell you the whole story of the analysis, but I will tell you that some of the results I think are notable. This resulted partly through the intense engagement between the community and the agency, a very effective relationship built up. And finally, the agency really modified the leasing plan and protected key harvest areas. There were a number of mitigation measures that the community had been asking for well over 10 years, but they were finally put into place by the agency to protect the safety of fish and game, to monitor air quality and water quality. There's a really strong collaboration that built up between the local government, tribal governments, and the federal agency, and to the extent that now this agency is doing, actively soliciting help on doing more health impact assessments in future EISs. It contributed to a plan that for the first time in my years in Alaska did not go to court. There was no litigation on this plan. It was actually widely accepted by the industry, by communities, and by state and federal agencies. And probably most importantly, the Alaska Department of Health and Social Services now does health impact assessments on every large project in the state. This is a formal program of the State Health Department. They are funded entirely through the permit structure of the Department of Natural Resources. They're just one of the agencies, multi-state agency collaborative that's at the table for every large project. It's important to recognize in Alaska, natural resource development is the hugest part of the state budget, and this really is one of the major drivers of all of the determinants of health in communities. So you've now got the state health departments are fully at the table, engaged. And as far as the budget for this work, the medical epidemiologist that runs this program describes it as a rounding error in the department's budget for permitting these projects. So this is the tool. I'm not going to bore you by reading this definition. I only include this slide to tell you that you can download the National Research Council and IOM's report on HIA free at the National Academies Press. Flo did a fantastic job of introducing health impact assessments, so I'm not going to redo that, and I get to give you a few more examples. Take you to a totally different policy arena, just partly to make the point that HIAs are really being used across a broad range of social, environmental, economic, and physical environmental policies. In this case, after Hurricane Katrina, energy prices spiked considerably, especially in the Northeast, which had a very severe winter at the same time, very bad timing. The state legislature in Massachusetts was considering whether or not to increase funding to the Low-Income Housing Energy Assistance Program. Was not viewed as a health policy. No one was talking about the health effects. But if you think for a few minutes, it's not hard to understand that when people have trouble heating, they turn to unsafe sources of heat. Space heaters to heat a single room where people may crowd into that room. Infectious diseases, carbon monoxide poisoning, burns, and pneumonia being some of the real risks, as well as people making very hard decisions between whether to buy food, to pay for heat, to buy medicines, etc. So this report mentioned, without quantifying, that this would have implications for Medicaid expenditures because many of the beneficiaries are also publicly insured, and recommended increasing funding for the program. The state controller noted the HIA in making a recommendation to the legislature that the funding be increased, and noted the fiscal impacts. And this did result finally in a decision to increase funding to the LIHEAP program. So just to give you an idea of what's happening with this field, I think that the growth of the field, this is 2007, this is now, just really, and actually this is out of date. I'm told by my staff that we're up to 275. So it's really increasing, and I think this just points to the need. This is one tool that people are turning to begin working more effectively with other sectors. One more example. The Healthy Hunger-Free Kids Act required USDA to regulate the sale of snack foods and beverages in schools, so-called competitive foods. An HIA looked at the health benefits of having less student access and therefore purchasing and consumption of unhealthy foods and beverages in schools, but also addressed a key question for the USDA, and this is really a point I want to emphasize. One of the issues that we find HIAs often doing is taking is working with decision makers to address the decision on their own terms. USDA was wrestling with a key concern from school districts around the country. What's going to happen to the revenues? We need these revenues for other school programs. So the HIA actually did a big analysis looking at all of the available administrative data from around the country on the issue of revenues and what happens when districts enact policies that restrict the sale of snack foods and beverages, and found actually quantitatively that it was likely revenues would actually increase because more kids would go to the school meals programs and those are things that schools are reimbursed for. So ultimately USDA cited the HIA extensively in the regulation and said it really added to and enhanced the final rule. So HIAs are addressing a lot of topics: local, state, tribal, and federal decisions, social policies, land use, transportation and housing, energy and natural resources. And I think we're really seeing people experimenting with where does this work well? Where is it the right tool for the job? We're seeing, I think, both concrete policy changes of the sort that I've shown you a few examples of, but also systems changes. Very importantly, I think new partnerships and routine collaboration between health and other agencies. And one of the things that we're seeing that's really important that I think speaks to Martha's earlier question about the funding, if we had to do an HIA on every decision, it probably would break the bank and it would also slow things to a halt. First of all, we see HIAs being done rapidly, so you can do it in a month or two rather than a year or two. But second of all, we also see people who've been doing them for a while saying we don't do a lot anymore. We've worked ourselves out of that job. We now know how to collaborate with the planning department, or we've built other tools that allow us to do it more systematically. So I think this really goes to the second challenge, which is time and workload. And we're seeing HIAs not just as a tool to inform a single decision, but as a tool to build effective collaborations and then build the tools that you need to collaborate more in a more streamlined manner. So I'm going to finish here. As I said, I'm a physician. I spent my entire career in clinical practice taking care of low-income people, both in urban environments and in rural Alaska. This isn't a new conversation, right? Social determinants is a rebranding of sorts of problems that we have been fighting against for, many, many years, centuries. This is a fascinating example, right? The typhus epidemic in Upper Silesia. Most people probably are familiar with this. But the finding was, but typhus didn't act alone. It was a cofactor: poverty, poor education, abysmal housing. Those were the real upstream causes. And the cure: long-term planning, interagency council, free education, reform the tax system to alleviate poverty. These are the things that David started the day with. So why aren't we making progress? I'll step outside of my role as an HIA advocate just to finish, because you're a thoughtful body and are going to do a lot of thinking today and tomorrow, and ask, I think if we identify that the goal is improving the conditions to allow more people to be healthier, we've spent the day talking about one strategy, which is policy reform, and tactics, which involve working within the policy structure to do that. But I think another thing that we need to think about is what is the role, and do we need a social movement? Many of the important changes that have really led to improved conditions for people in poverty relate to the Civil Rights Act, to worker protection legislation, to women's suffrage, et cetera. Those all came from social movements, probably not just inside legislative policy. So I think it's important to think, what are the tactics to get there, and what contributions can people in this room make to that as well? Thanks so much.
Thank you, Aaron. Our next speaker is Lowell Solomon, and Lowell is the Vice President for Community Health at Kaiser